Well, welcome everyone. My goal for today is just to walk you through the current strategy related to Medicaid transformation with a focus on intergovernmental transfers. And Devin will be tracking any online questions, and if you have questions as we're moving through, feel free to interject. In the meantime, it would be awesome if you would mute your phone. We're hearing a little bit of feedback online, and I will apologize in advance. I'm actually sitting in the airport at SeaTac on my way to a Healthcare Authority meeting, and so there's a little bit of background noise here as well. So we'll go to the next slide. Well, goodness, that's always exciting. Just to start us off with a foundational piece of information is some background knowledge. So as we all know, on January 9th, 2017, the state of Washington and CMS agreed to the terms and conditions for an 1115 waiver, providing up to $1.12 billion over 5 years. As we all know, these dollars are performance-based, and we have to earn them based on a series of both paper reporting and paper performance milestones. In order to draw down this full amount, we must provide some local match in the form of intergovernmental transfers, and you'll see us referring to those as IGTs as we move forward, and designated state health programs, affectionately referred to as DSHB payments. Somebody's is not muted. Do you mind muting yourself? It's one of the people on the phone I can see from our. We are going to focus today on the intergovernmental transfers. And so here's just to give you kind of a working knowledge of what these are. These are transfers, as they sound, between governmental entities such as counties, public hospitals, or other state entities. These must meet state and federal requirements. So that's, I think, one of the points of which we need to be aware of. And that these IGT contributors are expected to participate in each of the accountable communities of health, earning incentives as a partnering provider. So I think that's an important notion for us to capture as we think about this moving forward, that we would be engaging with these IGT contributors in much the way we would with our local public hospital district or community-based organization in that way. And that the IGT contributions must comply with the special terms and conditions. So these are really the elements that are governing the state's use of these $1115. I think it's super important to note at this point that the IGT and the designated state health programs are built into those STHCs. So while we may not like them, this is the funding mechanism with which the state and CMS has negotiated, and I don't think there's any appetite on either CMS or on the state to renegotiate those because of what it would mean to the overall project. We'll go to the next slide. So I want to use this visual to just try and explain how it actually works. We had seen a different version of this, I would say, for the board presentation. And so I'm going to start on the left side in the gray column. So this identified IGT contributor contributes $10 million to the Healthcare Authority. The Healthcare Authority then demonstrates to CMS that they have possession of that, which draws down an additional $10 million in federal support, creating a total of $20 million. Those $20 million are then put into the statewide DSRIP pool. So that's the Delivery System Reform Improvement Effort Program. So that's how we're drawing down all of our local project money. So then each region has been allocated a share of those dollars, and BHT would have its own share that it's drawing down. So we've been talking of late about the $10 million of project funds for this year. That is coming out of the DSRIP pool. The ACH or BHT would then allocate $7.5 million into our regional transformation projects. So that's when we think about the collaborative, the regional infrastructure, the community resiliency dollars. That $7.5 million would go into that pot. And then the balance of that investment would be developed in a relationship with the IGT contributor. And right now we believe that those contributions would help fund our Domain 1 activity, which is value-based payment, HIE and HIT, and workforce development. Each of the ACHs in the state would register and approve those partnering providers independently, and then we would authorize those disbursements. Maybe I'll pause there and see if there are any questions or comments about that before we keep moving on. Okay, maybe this is starting to be socialized enough that we're all starting to have a good working knowledge of it. Let's go ahead and move to the next slide. So in working through this, there are a set of assumptions that we want to make sure everyone is sort of aware of. So it is the state's responsibility to identify both the DSHP and the IGT contributors and develop the sort of high-level contractual requirements to operationalize this. It is not individual ACH's responsibility to go and find those. If all 9 ACHs don't agree to the strategy, it reduces the total amount of DSRIP funds that would be available. The IGT contributors, by the STC and the requirements yes, that's how I feel too. Must be voluntary, but they must be given an opportunity to earn incentives like other partners. The currently identified IGT contributors, which are the Evergreen Hospital, Valley General, and the University of Washington, are well positioned to provide Domain 1 services across all 9 ACHs. For our region, we may have some commentary on how well positioned all of them are, but the state feels confident in that. And that the ACH has to approve the distribution of funds. So if you go back to the previous slide, Devin, on that $12.5 million underneath the collaborative projects there, those dollars have to actually be approved. So they will run technically through BHT's governance structure. Go back to the slide. Any questions or clarifications I can make on that?
Allison, this is Sharon Fairchild. Do we have any information from the Healthcare Authority about what are the qualifications for an IGT contributor, and do we have any opportunity to ask them to approve any Eastern Washington potential partners?
Excellent question. So an IGT contributor really could be any governmental entity. So that includes both public hospital districts, cities, counties, as well as tribal governments. So it's a very broad definition. And the Healthcare Authority said it is very, very interested in exploring Eastern Washington IGT contributors. It is my understanding that the 3 identified contributors were able to put up the full amount of match, which I think is roughly $500 million across those 3. So I think they went with a strategy of less contributors to get to the full amount so that we were sort of secure in actually having those matches. And there is no restriction on how small the contribution would be for it to count, nor any geographic limitation. It would just allow more dollars to sort of be in that pool, and then being able to draw them down. So I will say that we are working in partnership with the Healthcare Authority to identify the right folks from both WSU, Eastern, and then I have an inquiry out to all three tribes to explore what that might look like for a tentative meeting scheduled for March 14th. So I want to share that as they are demonstrating their commitment to working with us. It would be important to note that those contributors wouldn't be part of the year one IGT contribution. We're too far into the process to be able to do that. Does that answer your question? Yeah, go ahead.
If I could just do a follow-up. My understanding is that the only way you get the money for, in Domain 1 project is if you use an IGT contributor. Otherwise, it comes out of our regional funds, correct?
That is technically correct, though I would reframe it in IGT contributors could be providing support across things beyond Domain 1. So in any of our project areas, I think the three entities that have been identified fit closer to preparing for value-based payment and workforce development at this point. And so I think it's getting captured as if these are the shared investments across Domain 1 and how you would access them. That isn't exactly right. It's just what we think they could contribute falls into Domain 1. Does that answer your question, Sharon, or any follow-up on that?
No, that answers my question. Thank you.
I mean, I don't know that it answers your question, but it's a statement related to that, or any other follow-up.
No, I'm good. Go ahead.
Okay. Any other questions?
Yeah, this is Aaron Wilson. Do you have an example of how those things would work? Whatever the services, the Domain 1 services we would be needing a contract for. I mean, what the logistics would look like, understanding we're all sitting, nearly 300 miles away from the Puget Sound.
Yes, that is great. So it is our intent to have Ben Lindenkugel from the Washington Public Hospital District Association at our board meeting, laying out what the association has really committed to for IGT. But I'm happy to share sort of at a high level what their agreement is. And I think, part of what we wanted to do this briefing, not in a public setting, is the language the Healthcare Authority has to use to not be in violation of the CMS requirements does not really invoke what I think is the actual relationship playing out here. And so Ben will share this and in his presentation, but they started negotiating, the Public Hospital District Association started negotiating with the Healthcare Authority in 2015. And they agreed to put up what I believe is $100 million. And they chose their two largest public hospital districts because they could easily put that up. And the agreement with them was, obviously, they would get their collective investment back, as we would expect. And then you may remember a comment around a 25% return on investment. So that's been the working assumption that the Healthcare Authority has had with these IGT contributors. The Public Hospital District is proposing that they would spend that 25% ROI in the following ways. One, there would be a 10% ROI to the IGT contributors, sort of right off the top. The next 15% would be split, and he hasn't shared with me what the exact split is, which may be because they haven't decided, or he will share it next week. But the first chunk of dollars of that remaining 15% would go to frontier hospitals who have some financial sustainability issues. And in our region, we have a couple of frontier hospitals that I think would fall into that category. The second sort of pool would be to support the association's work across the ACH efforts. And then the chunk of it, or the majority of that balance of the 15%, would be allocated across the 55 public hospital districts in the state, with a focus on utilizing those dollars to support their transition to value-based payment. And so it'd be very similar to how we've been thinking about funding in terms of they can spend the dollars how they see fit. I would imagine there's some contractual requirements to draw down those dollars, but it would be really trying to prepare what is a generally considered fragile rural health system. And I think we could easily make the case with 5 public hospital districts and a couple of sort of true frontier public hospital districts that there would be value in having those dollars come out of that domain one shared investment, because of sort of our expectation of how project funding will start to flow based on, after we get through this first year, some level of a volume model in that way. So I think that explanation of what the dollars could be was a lot more helpful than sort of the ambiguous way the Healthcare Authority was describing it before.
And Allison,
to give you a little more sense, Aaron?
Yeah, I was trying to figure out the incentive for the IGT providers, and just, what mechanisms are in place for when they receive their initial investment back, as well as then the additional 25%, what's required for that to occur. And then since that 25% is coming out, my follow-up question would be, is that reflected in our estimates of total dollars available if we were to go through with the IGT?
Yeah, I've got a slide that shows the effects of the IGT contribution that I'm happy to put up. And I would say that there is still some amount of negotiation still to be had, both with the Public Hospital District Association as well as the University of Washington, about what sort of the deliverables will be. It will be very important that these are structured in a way that doesn't look like quid pro quo. So there has to be, as you'll note on some of my IGT assumptions there, that there has to be both an ability to earn those incentives, and we would expect an expectation of earning those incentives. That I think you could think the first part of your question about why would they do it. I think on the one side of it, there's a 10% ROI, and on the other side, I think the Public Hospital District Association was working sort of to support the fragile rural health delivery system, and this was a way to add some additional dollars into there. And then I'm happy to talk through on this next slide the IGT effect. It sounded like there was one other. I'll come back to that, Aaron. It sounded like there was one other question. Comment?
There's a couple of questions in the chat box from Ron and Julie.
Great. I'll look at those. Okay. Okay, so the first question is, when does the $10 million go back to the IGT contributor? I probably need to have a more formal answer for this, but I believe it's a pretty fast turnaround in the 24 to 48 to a few business days. So it isn't like the money's going to sit someplace for a long period of time, hence the push to try and get contracts in place so those dollars can flow quickly. Julie is asking, how would Evergreen Hospital be a BHT partner in Eastern Washington? I think though we are considering Evergreen and Valley General as the IGT contributor, it's really on behalf of the Washington Public Hospital District Association. And part of why they're going to get a little bit of that 25% is to help support all public hospital districts in that way. So it wouldn't necessarily be that Evergreen was providing us services as much as the allocation agreement for our frontier hospitals and the public hospital districts in our area to participate. And then the incentive for an IGT contributor to tie up their cash, I think in the instance of the Washington Public Hospital District, it was a 10% return on investment for, I think, that cash not being tied up for too long a period.
So Allison, this is Julie. I don't know if you can hear me or not.
I can.
Okay, so maybe I'll just throw this out there, and it may be kind of a crass statement, but I don't know how else to kind of state this. So is it correct to say that essentially the amount of money that we thought we had to work with is substantially less because now IGTs are in the mix and will be driving a statewide solution, not a local solution?
Devin, can you go ahead and put the next slide up? I think that is a true-ish statement, though in total, I would say in accepting the IGT contribution, our dollars go, our locally governed dollars go up a bit. And then, of course, we have influence over these shared investments with the IGT contributors. If we were to not agree to this, then yes, that is absolutely 100% true. We would have significantly less dollars available. So why don't I just walk through this, and then we can open up for some additional questions and comments. So what you'll see in my chart here is years 1 through 5 with a total at the very bottom. This first column are the secured DSHP payments. So the state has effectively secured those dollars for the 5-year period. They had negotiated with the Fed that there would be more DSHP payments in the early years and more reliance on IGT in the late years. The share of our total project dollars related to IGT is in this next column. And you will see that increasing amount of our dollars being tied to IGT. I pulled out the FIMC dollars, one, because we think about that as a separate sort of bucket of money. It really comes out of that same district pool of both DSHP and IGT contributions. I believe it is safe to say that those dollars are 100% secure IGT strategy or not for year 1. I cannot say that with as much certainty for year 3. So this next column then is the total dollars that project dollars that we will govern via the Medicaid Waiver Finance Group and ultimately the BHT board. So that's $64 million if we agree to the IGT strategy. The next column is the fairly newly released VBP incentives that if we continue to move towards meeting those VBP targets, so 35% this year, 50% next year, getting to our 90% goal in year 5, there will be additional dollars. And we believe that those dollars will run just like those project dollars, so they actually come out of a different pool, so they're not tied to the IGT strategy as much. So giving you sort of this total amount that BHT will technically govern with sort of no constraints on another ACH interaction or anything in that way. Then you move into the next column, of which totals out to $46 million. And without a doubt, as you get into years 4 and 5 much more for the good of the state, investments being paid out of there. And so then showing this 113 million total for the region, that, you know, is significantly higher than, you know, sort of our initial estimation without IGT sort of carve out of 90 million before we talked about the 30% cut. So we've earned back some of that, though, sort of less truly flexible dollars. But if you were thinking about not moving forward with the IGT contributions, you're really looking at 40 million versus 64 million, which seems really significant in my mind as we think about both a rural and urban strategy and really linking both the healthcare delivery system with the social determinant of health. And then that last column is just noting how much of those dollars would be at risk based on not meeting the performance metrics. So I do think that was a helpful calculation for us to understand that, well, $7 million or almost $8 million is a lot of money when you're comparing that to 67 million, not as much at risk percentage-wise from that standpoint. So, Aaron, I want to go back to your question. Does this come closer to answering that?
A little bit. I guess my question would be specifically with the shared investment with IGT contributors. Is that just our region specifically then? That's the $46 million total?
Yes, that's just BHT's portion of the IGT contribution. The total for the state is about 500 million.
So am I right that I'm counting 2 IGT funding streams?
Right now, it is the UW funding stream and then the Public Hospital District Association funding stream. That's correct. I don't know that I'd call them funding streams as much as they're the contributors, but, and I believe the number is 100 million for the Public Hospital District and 400 million from UW.
Allison, do these dollar amounts represent after the 10% return on investment and the 25% reduction come out?
Mm-hmm. They do. So that would be if we figured just for round numbers that of that IGT, that shared IGT of 5.2 million, that $1 million of that was going to the Public Hospital District, that would include both the initial capital payment or principal payment, and then that 25% would be part of that as well. It's not, we're not pulling that 25% out of our other dollars, I think is what you're really asking.
Allison, this is Sharon again. Another follow-up question is the 46 million under the shared investment. Does that mean that $46 million is going to the IGT contributors for the Domain 1 projects?
I wouldn't say that it's necessarily going for the Domain 1 projects. The way I think the current thinking is that they would support Domain 1. And yes, at this point, they have that 46 million would be going to the Public Hospital District and UW based on the current structure. If we were successful in figuring out how to support our tribes in workforce development, for instance, around like the DHAT, then there would just be a bigger pool of match dollars available for our region to draw down. I think it's hard to imagine that you could get the statewide effect if it wasn't Domain 1 investments, but I don't think there's anything from what I can gather from the terms and conditions that wouldn't that couldn't be supported in that way. So I think one of the things we'd be interested in exploring is, was there any way to get, pathways technology covered through that, which could be sort of care coordination rather than, a domain one investment. I think this is part of that language issue. I think it's easier to try and explain how you would create value across the entire state, talking about domain one shared investment. And I think in the agreements that have been formed to date, of which I have not seen the specifics of the Healthcare Authority, I'm hoping to this afternoon, or at least get a sense of that at the Healthcare Authority meeting I'm at today. But if you use the example of the Public Hospital District Association, you could start to see how that would flow.
Allison, this is Bernie.
Go ahead.
With the effort from the Healthcare Authority's perspective to have impact across the state, does that indicate that we are somehow subservient to whatever the IGT wants to do across the state? And does that direct kind of how those dollars get spent, or what say do we have locally to direct either the Hospital District Association or the UW to be focusing on our priorities?
Well, I think, it's probably a pretty gray area. So in a technical sense, we will have a contract with UW and the Public Hospital Association to both release these dollars and agree to some set of deliverables. So we have a lot of influence on sort of the IGT strategy. If we say no, then there's less dollars available to the whole state. And if we say yes, but we want to make sure that, I think one of the things could be if we were concerned about where those UW dollars were being directed, that would either not support Eastern Washington, or we just don't see value in there. We could talk about that not being part of our contribution in that way. I think that it's also important to note that we can't say, well, we only want of this year's $5 million of IGT contributions, we only see value in $3.2 million. Like, you're sort of agreeing to this amount because that's the financing structure. And I think the reason it gets so confusing when the Healthcare Authority says that is they need to make sure that it's not quid pro quo and that this still appears to be voluntary. But you can imagine that if the contributor felt they had negotiated for a 25% ROI, or this sort of shared ROI investment in the way the Public Hospital District, and it came back that they only got 3%, they're not going to be in for the next year. So there's sort of the technical part of this, and then on the other side of it, the practical part, which is if we can't come to an agreement, we're not going to agree to fund to the IGT strategy in year 2. And if we're asking too much and they decide this isn't worth the headache, whatever, then they walk away. So we're definitely tied to each other, and I don't think anybody has sort of the true upper hand, although I would say that, the fact that there's only technically two contributors gives UW some level of leverage to be able to say, this is what we're willing to do. That being said, this afternoon, we're going to have an opportunity to be with both the Public Hospital District executive as well as the person who's been negotiating on behalf of UW to sort of understand. And in my preliminary discussion with UW, they said, we're really committed to making sure that there is value being created. And we're using examples like the Washington portal that has been created as part of the SIM funding, and being able to extend the reach of that, which would be of value to us. They were talking about the McCall Center and some of the work that they've done. I think it's on chronic disease. I'm getting things confused in my head. It might be behavioral health, and being able to provide practice support in that in that way, of which we know there are partners in our region who've been accessing those services. So I think this is probably less of we are funneling money to, you know, UW Medicine's clinical practice and more about, you know, infrastructure investment, whether it's consulting support or something else. I know that I have been seeding with the healthcare authority that, you know, when we think about workforce development, both the primary care residency opportunities, but I think, you know, sort of across many specialties that could be of value, possibly less to specifically our delivery system reform work that we're putting here, but would be very much aligned around, you know, the region's efforts over the next 10 or 20 years to increase the pipeline in that way, which I think sort of then becomes incumbent upon BHT to start trying to bring along local contributors where we would have more influence on, yes, I can see this both as a workforce development, but it's also the dollar staying in Eastern Washington to support people who really understand Eastern Washington. Does that help? Maybe, maybe not. Are there other?
That's helpful
Yeah,
for me. I think I'm just trying to understand if the value we're going to get back from the IGA investment really serves our needs, or if it's more directed by a statewide effort that obviously will predominate from the west side.
Yeah, let's go to the next slide, Devin. This just gives a little bit more clarity, I would say. Again, I think there is sort of a number of things still to be negotiated, and it's pretty hard to have said yes to the strategy and feel like you have a lot of negotiating left. That being said, we would really be asking the board next week to make a decision on year one, on the year one IGT strategy. And we could put into that policy statement that, you know, these expectations around contributions being of value to Eastern Washington and good faith negotiating happening in that way, an active effort to recruit Eastern Washington IGT contributors. And when we come back to make our next round of allocation or allocation decisions for year two, if we felt the good faith wasn't there, we could then step away from the investment moving forward. So there's a bit of an out, I would say, for the long term. And when you look at the financial portion of this, I think one might decide that the IGT contributions may be helpful and may not be, but I would be disappointed if anything was negotiated in a way that overtly disadvantaged Eastern Washington, not just our region, but the other two ACH regions in there. And some of that we won't know until we move further through the negotiation.
Thanks.
The other thing that I will say, and I need to get some specific language from the healthcare authority, but it's my impression that we allocate twice a year to these IGT contributors. And so if we thought about the $5.2 million in year one, you would actually be only allocating 50% of that. So you will have some opportunity to keep coming back and revisiting this as we move through the negotiation process. And that I believe it is the Cascade Pacific ACH. One of the ways they were thinking about this is, while it's a larger amount than what we are triggering sort of for commitment and participation. You could really think about that first payment being a commitment and participation payment that really then triggered that implementation work, which is very consistent with how we've thought about how we're allocating dollars. Now, they would get more money than how we've structured it. So I get there's a little bit of an equity in that way, but conceptually it would be a very similar process to what we're saying. Other questions?
Tim O'Connell asks if we will please email these slides out when time allows.
You bet. I will send it to the full group as soon as we're done here. Let's just walk through this last. I think there's just maybe one more slide. So this is just. I wanted to be careful. Saying things that I haven't seen in writing, just I have heard verbally. And part of the reason we're inviting Ben to the board meeting is that he will walk us through the agreement that the Hospital Association has with the Healthcare Authority. But you can see that the shared investment opportunities would be around our Frontier Public Hospital District and then investment in the rest of the public hospitals that we have. And then the couple of identified partners that or programs for initiatives, I'm not really sure what we call these at the University of Washington, is the Washington Portal for Practice Transformation and the AIM Center. The next slide, please. Oh goodness, I hadn't told you to go to the next slide yet. So there's the shared investment opportunities, and then we'll go to the next slide. For the board members, on just being really clear about sort of what we would need to do and sort of the impacts of that. So on February 21st board meeting, we'll have a discussion, and the real, well, I suspect we will make a full policy statement on this. The real thing is just an agreement to put into the portal those three providers, so Evergreen, Valley, and UW as IGT contributors. We're not agreeing to pay them any money, but they need to be in the portal by the end of the month. In March, the Healthcare Authority has said that they will release project money that is funded through DSHP. If we go back and see those dollars, I believe it's about $8 million in year one. Those will actually be available for us to distribute to partners in the month of March. So that's really positive in terms of what you all approved. And then in March, the board would need to approve the actual IGT contribution. So there's not a lot of time in between, yes, we agreed to the strategy, and now we're actually allocating. And again, I think it's just 50% of that 5.2 million, but it would be part of our funds flow process to have the board formally approve that. And then in May, we would receive the balance of the project money that we had earned, of which we learned today was we earned 100% from our project plan. So the balance of those dollars would be available for us to disperse to partners in May. Any questions?
Hey, Allison.
Yeah.
Yeah, this is Peter. Could you just, for the part of the learning here, remind us, and it may be on a slide, which I don't have access to the computer right now, if BHT were to choose not to participate, what's the delta of dollars, the decrease that BHT region would not have access to?
Great. Devin, can you go back to the money slide? So Peter, on this slide, in year one, it would be $3.1 million of IGT contribution that we would not have direct governance over. And then, of course, you wouldn't have the $5.2 million of shared investment.
Okay. So total dollars we would, as a region, if the board were to decide not to be comfortable supporting this, we would lose access to $8 million? Or I'm just trying to get a sense for all of us.
In year one it would be $8 million. But you can see as you move into years 4 and 5 how little you would have both because of the percentage that's funded from DSHB and IGT as you move through this. So less in the first year and increasingly more.
Okay. This is Aaron. I mean, 8 million is a big number. I don't know whether we should be including those outside investments that we don't directly control, because we don't really know how those dollars are actually going to be utilized. So,
no, that's
the
why
total for the 5 years
actually broke that out. Sorry, Aaron.
Well, no, I think, so to Peter's question, over 5 years, the dollars that we directly control would be reduced by about $24.5 million, which is a significant number.
Aaron, is it 24.5 or is it 70 million? Is it? Allison, can you clarify that?
Yeah, so it's 24 million that we would have direct governing authority, meaning that 24 million would, I think it's safe to say, only go to providers in our region. The 46 million is sort of shared investment, of which one would hope there would be value. But if we didn't get any Eastern Washington IGT contributors, technically that 46 million would land in those three identified contributors. So yes, you have lost $70 million worth of investment. But I think trying to break that out into this 24 million that would be directed very specifically to meet our 4 project areas plus the other ACH related work through our collaborative structure. That being said, this is why I think this gets really confusing in the discussions with the healthcare authority. They will keep saying, no, you're actually losing 70 million that you're governing. But I think why I wanted that separated out is that 46 is sort of governed collectively across the state with the set of contributors and what they would be willing. So that feels a little more like, a restricted grant that says, sure, you can spend this money however you want as long as you do it in one of these, sets of areas, versus literally the 24 million that's in the IGT column could be spent however if we have earned those dollars, we can spend them how we see fit.
Allison, doesn't it say that the shared investments with the IGT contributors, for that money to be distributed, the ACH has to agree that those services will be used and have been used effectively within our region?
Yes, I think it's probably dangerous to think about this as services provided and more about infrastructure available, which I realize is, sort of playing around with language in that way. The IGT contributor, in practical terms, if they agree to do this, will expect to get $46 million worth of payments from BHT to them. And in order to trigger those payments, we will have agreed upon a certain set of milestones to do that. So it's not that I have bought 100 hours of consulting work from the AIM Center. It will be that the AIM Center has contributed to, whatever the however we frame the milestone, very similarly to what we're saying to our partners, where, you know, improvement in these statewide metrics may trigger a payment to you in that way. So I think it's a little dangerous to think about sort of this menu of services, and more about, yes, there will be some contractual agreements because we will have that in place, but it's less of a sort of straight line equation, I would say.
This is Kim. And, you know, there have been several times now mentioned the opportunity to potentially add some of the East Side folks into IGT starting in year 2. And I guess I would just like to be sure that we obtain some clarification. It's my understanding in talking with Ben from AWPHD and through WISHA that the reason for choosing the partners that they chose was that there was a requirement for a commitment to participate all 5 years under the IGT, and they did not feel that they felt that those were the only partners that could commit to the amount of money that was required to do the intergovernmental transfer over all 5 years and not be at risk of not being able to meet the requirements. And so I'm not sure that adding new partners in the second year is actually an option.
I think it may not be an option for the Public Hospital District Association based on what you said. I think those are their constraints, not the state's. I don't think they're interested in a bunch of, you know, $100,000 contributions just because it'd be an administrative headache for everybody involved. But both my conversations with OFM and with the Healthcare Authority has assured me that they can add that. I don't know that if Newport decided they wanted to do it, that the Public Hospital District has the capacity or the desire to do it. I had understood it was more about, as you were saying, who could put the money up sort of in the most efficient way possible, that this wasn't about everybody contributing a little bit, despite the fact that they're sort of spreading the value across everyone. But each of those agreements are negotiated independently.
Thank you.
And I guess the other thing I would say on that, Kim, is that the Healthcare Authority has agreed to come to Spokane on March 14th to meet with some potential IGT contributors. So I would have been a little more skeptical of like, yeah, just approve it if we weren't moving towards actually having a meeting to discuss it. So.
Very good. Thank you.
You bet. Other questions or comments? Peter, does that get at the sort of crux of your question there?
Yes.
Excellent.
As best as possible at this point.
Well, exactly. It'd be so much easier if you could see me wildly gesturing with my hands as well.
I want to, Allison, this is Peter again. I just want to acknowledge you here. You're a messenger here of a message that was not of your making, and that we're all working hard to understand and to do what's best as you are for our region here. But I want to just thank you for yourself being in an awkward position. And I think you inviting people to the board meeting who can speak to this, who have ownership of it, will be helpful for all of us, because I realize we're asking you a lot of questions that, again, were not of your making. So I just want to thank you.
I have done lots of good deep breathing over the last 10 days.
Yeah, I'll bet. This is really, really, we know this is hard for you here too, but I think we really do at the board meeting want to have a really thoughtful and really very complete conversation with the experts that you're bringing in on it. So thanks.
You bet. So Devin, can we go to the sort of conditional, probably, it might be the very last slide. So my recommendation after the series of conversations I've had, and assuming this afternoon's meeting is productive, is that we would offer a conditional yes with a few sort of conditions put in place. First, we believe that some hold harmless language would be very important in whatever sort of moves through this. That was sort of an early concern that many of us had, that this felt less clear what would happen if CMS came and audited the organization and decided, well, that wasn't an appropriate allocation in that way, and that we had no way to repay those dollars. And so we have been assured both from the Hospital Districts Association that they did not think that that was an unreasonable request, and also from the Healthcare Authority to work through that. The next piece was to provide ACHs with influence and partnership on these shared domain one selections. So today is step one with the Healthcare Authority, the IGT contributors, and the ACHs, and a commitment from the Healthcare Authority to make sure that in a fairly rapid succession of time over the next 6 to 8 weeks, that we can sort of move through the set of requirements and negotiations, so that by the time we moved into the May period of time, we felt good about the understanding and agreements in that way. The next would be to provide us with the opportunity to work with some potential Eastern Washington IGT contributors, and we have a tentative meeting for March 14th. So there's many of you that I think I'm going to want to try and engage in some brainstorming at the WSU level, as well as Eastern, and then I've already done a little bit of outreach to the 3 tribes to at least sort of come and have an informational meeting about how this could work. And then the final piece is there is still not any written guidance from the Healthcare Authority about the funds flow and fiduciary responsibility and authorization. So we would say yes, but we want to see that actually in writing. And certainly, you know, if anybody wants to add anything to that list right now, I am imagining after the board discussion there may be some additional things, but these were the ideas that seemed most important to acknowledge from the conversations I've been part of. And my staff recommendation would be to move forward with this strategy. We are right at 1 o'clock, and so I know we're going to start losing people. Let's just do a quick check on the chat. Tim, yes, we will send the slides out. And Julie, I did say we scored 100 on our project plan, so we have earned 100% of our year one dollars. You may have heard the collective shriek from BHT this morning.
Great job on that, Allison.
A labor of love, one might say. We're really proud. We thought that would be true, but it was very nice to see it actually written down.
Yeah, as you should be.
Okay, well, I don't want to keep people on the line too much longer. BHT board members, if you have any other conditions or questions that you think I need to make sure that get addressed at board meeting, please don't hesitate to let me know ahead of time. The more groundwork I can do to have some definitive answers, the better. We will include in the board packet, and I will also share this with the Waiver Finance Committee, an FAQ that we've developed on this based on a number of questions that our colleagues from around the state have completed, and we've compiled that into a document. So I can do some additional work on that. And if there aren't any other final comments, I will sign us off. Anything for the good of the order? Okay, thanks everybody. Have a good day.